Okay, let's see. Go share screen. Cardiovascular 2. Okay. Okay. So I got a few more seconds and then I'll start. I don't know if it's recording yet or not. I'll wait till the allotted time. Okay. So this will be cardiovascular 2 out of the 3 cardiovascular lectures, and then that just leaves us lymphatics to do. And then I'll post this in the regular place later tonight. So cardiovascular system 2. So don't forget it's a closed system. So that means the red blood cells stay inside the pipes, inside the arteries, inside the veins, inside the capillaries, the arterioles and the venules. They don't go out into the tissues unless there's, trauma or something wrong. Um, so the arteries, we're not talking about the arteries on the heart itself or the veins on the heart itself, but arteries carry blood away from the heart and veins carry blood to the heart. Capillaries, small vessels, right? And that's the exchange vessels. So the O2 and the CO2 and nutrients and stuff like that can cross these, across from or to the capillaries. All right. So the veins, the heart, the arteries, arterioles, capillaries, venules, and back to veins. So that's a closed system. All right. It's just showing you some of the vessels. This is just showing you some of the heart muscle itself with the intercalated disc. You got little gap junctions between them. Okay. It's just, don't stress on this. It's just trying to show you that it's striated muscle, just like you have in skeletal muscle. So there's sarcomeres, calcium's released from the sarcoplasmic reticulum, just like in skeletal muscle. Don't worry about this part with the calcium coming from outside. It's a little bit different than skeletal muscle, but you'll learn about that in physio. We already went over these, the pulmonary versus the systemic circuit. Pulmonary circuit's going from the heart to the lungs and back, and the systemic circuit is going from the heart to the body and back. So the valves, we talked about these a little bit. So I just go right AV and left AV. So the right AV is the tricuspid valve, and the left AV is the bicuspid, and sometimes they call that the mitral valve. So this is horizontal cut, and you're looking down from above on it, so you can see the 3 leaves. So that's tricuspid. Here's the bicuspid. It's just got 2. So that's your right AV. That's your left AV. This is your tricuspid. This is your bicuspid. This is also called the mitral valve. These are just what they call semilunar valves of the heart. And so this is your pulmonary semilunar valve and your aortic semilunar valve. So I always had trouble remembering where these valves were. So I made up a little saying, because I kept getting these backwards. I said, well, I've gotten these backwards all my life. Now I'm going to try to get it right. So the tricuspid is on the right. Then if you tell me the other one's on the left, I might buy it. Mitral valve, bicuspid valve. So stupid little saying, but it works. Then I kept getting these backwards on top of everything else. So the pulmonary's in the front, the aortic's kind of buried behind it. So then I had a friend of mine that was going to PA school, and then I said, oh yeah, if he's got his stethoscope and he's listening to someone's chest, he goes, I'm a PA. So stupid, but it works for me. So the pulmonary valve's in the front and the aortic's behind it. So PA. All right. These are papillary muscles. So papilla, remember, it just means nipple-like projection. So they look like little nipples, and they're connected to these chordae tendineae. It's hard to spell. Make sure you spell it right. if I ask it on the test. So those are little strings, right? And they don't pull the valves open, although that looks like that's what's going on here. No, these are slack right here. So they're act more like door stops. So when your ventricles contract and the blood goes back up, it would just shoot right back up into the atrium if it weren't for these valves, right? The blood would go back into the atrium, but you don't want that. You want it to go out your aortic valve and your pulmonary valve. So these have to slam shut. And these papillary muscles kind of act like door stops, because if they didn't kind of contract at the same time, these valves could possibly blow back up into the atria here. In other words, the blood would slip past them and regurgitate into the atria. So these kind of help hold that valve down. So it's kind of like a door stop. And I told y'all the story how back when they first started looking at these, I guess it was ancient Greece or someplace, they thought they were heartstrings. So they thought they were like, it was like musical instrument. And if you got close to the one you loved, that your strings would vibrate with their strings, right? It's a good thought, but I don't believe it's true. But that's where that saying, like, she's pulling on my heartstrings. That's where that kind of comes from. Chordae tendineae, papillary muscles. Just make sure you can pick them out, because I can point here, papillary muscles. I can point here, chordae tendineae. I can point here, that's your left AV valve. So don't miss the easy point and name stuff. That would be your pulmonary valve. Behind there would be the aortic valve. Can't really see it. And there's your aorta. Okay. There's your apex of your heart. There's your interventricular septum. Here's your three layers. You got epicardium, myocardium, endocardium. I think you're starting to get it. All right. All right. And there's a real heart. And you can see the ear-like flap. They call it auricle. Sometimes folks use auricle and atrium interchangeably, which technically I guess they are. But I think more like the auricle is the ear-like flap on the outside, and the atrium is the chamber on the inside. But you'll hear a lot of docs and nurses using these two terms interchangeably, and I think technically it's okay. They'll say right auricle when they're really talking about right atrium, you know. Anyway, just so you know. And this is showing you some big vessels. There's your brachiocephalic trunk. There's your left common carotid, and you can't see it, but this would bend over and go this way. That would be your left subclavian. We'll talk about those more later, but those are the three big branches off of your aorta, off the arch of the aorta. This, by the way, that's your superior vena cava coming down. Notice the way nothing's colored in red and blue for real. That's just done on the models and charts. This is what it looks like for real. I'm not going to hit you with the lub dup. That's just the heart sound. So the AVs, when they close, it's a little bit deeper sound. And the dup is a little sharper, and that's your semilunars closing. When I say semilunars, I mean your pulmonary and your aortic. They're trying to get rid of that semilunar designation, and they're just calling them straight pulmonary valve and aortic valve. But everybody always calls them the semilunars that I know of. I'm not going to ask you which intercostal space do you put your little part of your stethoscope on to listen to, but this is just showing. They'll teach you this in nursing school and medical school. It's just where you can auscultate or where you can hear the valves better. Like if you put it here, you can hear the aortic valve better. You put it here, you can hear the pulmonary better. You put it here, you can hear the left AV versus right AV. So if you had a mitral valve prolapse or it was regurgitating and you put it here and it got louder, then that would probably be a good indication you got something wrong with your mitral valve. Let's see, chamber of the heart can be in one of two phases, systole versus diastole. Systole is just contraction. Diastole is just relaxation. So all the chambers do this, but generally when you're hearing systolic and diastolic pressure, they're talking about the left ventricle. So be careful if you go to the Northeast, like New York, up in that area, they say systole and diastole instead of systole and diastole. I don't know which one's correct. I've always said systole and diastole. Um, so this is just the normal blood flow through the heart. You can see here comes the blood from the superior and inferior vena cava. It goes into the right atrium through the right AV, into the right ventricle. Now it's going to the pulmonary semilunar valve and out the pulmonary trunk. Pulmonary trunk splits into pulmonary arteries. That goes to the lungs. And then you don't really see it that well, but coming back would be your pulmonary veins. The oxygen, it comes from both sides, right? From the lungs. And then the blood does. And then you go into your left atrium. So you see the way this left side of the heart is oxygenated and the right side of the heart is deoxygenated. So here's all this nice oxygenated blood making its way past the mitral valve or the bicuspid valve or the left AV, whichever one you want to call it, goes into the left ventricle, out the aortic valve and into the aorta. Notice why the artist drew this wrong. They drew the right wall of the ventricle thicker than the left. It's completely backwards. Must have just had a bad day at the art studio. The left ventricle should be thicker than the right ventricle wall. And I'm not going to do the heart defects this semester since it's teleconference. That's a weird one, tetralogy of Fallot, multiple defects. But here's one that you might want to pay attention to, this ventricular septal defect. It's just a hole, where the septum, the interventricular septum has a hole in it, basically. And so that oxygenated and deoxygenated blood can mix, and that can cause a problem. That does happen, but I think even probably more common than this is where it happens in the atria, in between the atria, because when you're a fetus, there is a little bitty hole there called the foramen ovale. It's a little foramen shaped like an oval. It's supposed to be there when you're a fetus because here comes the blood. Say this is coming from inferior vena cava, but a lot of that has been oxygenated at the placenta, right? And so it comes in and this blood's already oxygenated, so it can bypass the lungs. Some of it's going to just go straight over to the other side, right? Through that little foramen ovale. But when you're born, that foramen ovale is supposed to close. And sometimes it doesn't close and it causes the same problem as this. You're getting deoxygenated blood over onto the wrong side of the heart. Sometimes they call those blue babies. That's an old term, right? They can fix it now. It's a lot easier to fix now with a little, almost like a little scope type method. Used to it was an open heart surgery. All righty, we're not going to go into that. We're not going to go into that. Intrinsic conduction system. That's just how does it depolarize? How do the cells of your heart depolarize? So you got pacemaker cells. We alluded to these a little while back, last lecture. The SA node, sinoatrial node. That's your normal pacemaker. You have a backup pacemaker called the AV node. So we'll talk about that one in just a second. So these nodal cells establish the rate of cardiac contraction. So they're not really technically contractile cells. They just depolarize and repolarize, depolarize and repolarize. And that sends the signal throughout your myocardium when that happens, when that depolarization happens. So let's pay attention to the SA node. So what if I go, what's the normal pacemaker of your heart? And you go, SA node. You can call it SA. That's fine with me. Stands for sinoatrial. Now, if that one goes out, you have another one called the AV node, atrioventricular, but it's going to fire slower. So you normally default to the one that's going the fastest. But if this one goes out, say you have a patient and they have a normal heart rate, 72 or so, resting heart rate, then they come in a month later and all of a sudden their heart rate's 50. You need to start checking, see, do we have an electrical problem? Because odds are they didn't start running marathons and get a low heart rate in 1 month. Right. Now, these super duper athletes, like these marathon runners, they will have a low heart rate just because, compensatory mechanisms and all. So anyway, the SA node sends action potential to the conducting fibers. And so that's this internodal pathway. So let's look at it. So see, there's my SA node. It's going to fire. And then these little pathways, they didn't draw it, but it goes over to the left atrium too. They send that signal out. And then don't forget, you got intercalated disc in between all of your muscle cells too. So that helps spread the signal out. And then basically it gets that signal out really, really fast. And all of the cells in the atria depolarize pretty much simultaneously. And once they depolarize, then they can contract. Now that signal is going to keep going. It's going to go through this AV node and this bundle. This is called the bundle of His. Everyone still calls it that. They're trying to call it the AV bundle, which I think is kind of stupid because we have enough stuff that starts with AV. So I'm sticking with bundle of His. You can too, right? So the bundle of His is going to split into left and right bundle branches. And then you're going to go up a lot of these little fibers, and these are called Purkinje fibers. And so that's going to help spread that signal throughout the ventricles. So think about it. You want the atria to depolarize first, and then you want the ventricles to depolarize a little bit later. You don't want them to depolarize at the same time because then they would beat at the same time. So you want the atria to depolarize and then contract, and then you want the ventricles to depolarize and then contract. Okay. And Purkinje, I think that was a Czechoslovakian anatomist. His name was actually a lot longer than this, and they shortened it so everyone could pronounce it. He was, I forget when, back in the 1840s, I think he discovered a lot of stuff because he was the first one to cut up tissues in real small slices and look at it under a microscope. I think they call that a microtome. So there's your SA node firing, and then you can see how all these intercalated discs are also connected too. It's not really showing the internodal pathways here, I don't think, but don't forget all this stuff's connected, and then that signal, it spreads out pretty darn quickly. Okay, so if I ask you, what are the 6, name the 6 parts of the electrical conduction system. I could also call it intrinsic conduction system. You go sinoatrial node, internodal pathways, AV node, bundle of His, left and right bundle branches, Purkinje fibers, and then somewhere in there you can put in parentheses, everything's connected by intercalated discs to all those cells. All right. So this was on that first slide, and there's P wave, QRS complex, and a T wave. So these are just representations on the graph of the electrical activity of the heart. So the P wave represents depolarization of the atria. The QRS represents depolarization of the ventricles, and the T wave represents repolarization of the ventricles. Usually about this time, a student asks me, well, wait, where's the repolarization wave for the atria? Well, it's happening at the same time as this QRS, so you don't see it. It's kind of buried in there. So usually somebody says, well, what does the P, the QRS, and the T stand for? Where did they get those letters? According to Wikipedia, they just picked them out of the middle of the alphabet. They don't really stand for anything. So that's where they came from, P, QRS, and T. So all this is just, so what four things can you tell from an EKG? Notice EKG in the US, cardio is spelled with a C. They're trying to call it ECG over here, but this came from Germany, and I think it sounds cooler. So I'm sticking with EKG. You can tell the heart rate. So say this is 1 second apart, and these are 1 second apart. So you know you got a heart rate of about 60 beats per minute looking at this. You can tell rhythm, if they're nice and evenly spaced, you got a good rhythm. If some of them are closer together or further apart, you might have a rhythm problem. So rate and rhythm, that's two things you can tell. You can tell electrical problems if this P wave was scooted down here and it was taking a long time before the depolarization got to the the ventricles. You might have some kind of electrical block. So you can tell electrical problems, with the intrinsic conduction system. And if you had a heart attack, it's going to kill off some cells, right? And it could affect the shapes of some of these waves. And so you can actually tell if you've got cardiac muscle damage. If you have a good EKG before, and then all of a sudden you got a weird looking one after, you can kind of figure out what's happened. So that's the four things: rate, rhythm, electrical problems, cardiac muscle damage. That's four things you could tell. Okay, what else? Okay. Did that, did that. Don't stress on this too much, but it's just kind of cool the way they overlaid an EKG over the systole and diastole. They're talking about your ventricles here. So let's look right here. There goes my QRS. That's my ventricles depolarizing, right? So if you notice, right behind that is where you would get systole of the ventricles, because it doesn't happen simultaneously. It takes a little while. So you can see that's happening after the QRS went. And then here's my T wave. There's my ventricles repolarizing. And then you can see right here, my ventricles are relaxing. So that's diastole. So how would I ask this on, and this showing you which valves are open, how I would ask this on a test, I might would go, your atria are contracting. What's the position of your AV valves? Well, they're going to be open because the blood has to go from the atria into the ventricles. So if my AVs are open, my semilunars are closed. See, the semilunars. So now my ventricles are contracting, right? Systole. What's the position of my semilunar valves? Well, they've got to be open, because if my ventricles are contracting, my blood's going to my lungs and my blood's going to my body. What's the position of my AVs? They're closed, because you don't want that blood going back up into the atrium. That would defeat the purpose. So in anatomy, we act like if one set's open, the other set's closed. That's not exactly true, because you do have these little areas where everything's closed. But don't stress on that. They'll talk about some of that in physiology, like the isovolumetric contraction, that kind of stuff. We don't do it. So we just act like if your AVs are open, your semilunars are closed. If your semilunars are open, your AVs are closed. So we keep it simple. That's why I like anatomy. For tachycardia, well, I'm not even giving you numbers. Just know your resting heart rate's too fast. Normal resting heart rate's around 70, 72. I forget where they start calling tachycardia, but it's probably around 100. They keep changing these numbers on me. Ventricular, by the way, too slow. It's not on here. It's called bradycardia. Brady, B-R-A-D-Y. So bradycardia is too slow. Tachycardia is too fast. So I think of a tachometer on a car that measures your revolutions per minute, so that helps me remember too fast. Bradycardia, it's kind of weird, but it's kind of stupid. But if you remember that show, The Brady Bunch, if you're down to watching The Brady Bunch, it's probably a slow day. That's the way I remember it. I'm not going to go into preventricular contractions. You'll get that in another class. Fibrillation, I have asked a bonus question on that. So look here, the heart lost, all the cells lost their rhythm. So they're all just contracted willy-nilly. So they're not paying attention. You know, they're not in this normal sinus rhythm, they call it. So remember, cardiac cells can be autorhythmic, so they can just contract on their own. So this is just squiggling and squirming, and it's not pumping any blood. Well, it's not a heart attack, but it may as well be because you're not pumping blood, right? But if you get to them quick enough and you shock them with those paddles, you know, that's defibrillation. And if you're lucky, you'll just, boop, it'll just reestablish a normal sinus rhythm. Now, they may end up needing a pacemaker if this is, you know, if this is a real electrical problem. But sometimes it just happens, you know, and that's why they have these defibrillators at like the basketball games and the football games. They have them scattered throughout campus. They're really smart. They have little computers in them, and if you take CPR, they'll teach you how to use them. And the machines actually talk to you now and tell you what to do. And I don't think they'll even the machines. They won't shock them if they don't need shocking. So they're kind of foolproof now, supposedly. So the autonomic nervous system, just know the sympathetic's going to speed the heart rate up. The parasympathetic's going to slow it down. Remember our neurotransmitters, parasympathetic uses acetylcholine, so that's going to slow it down. Sympathetic is going to use norepi. Probably you're going to have some epinephrine in your bloodstream too. Same effect. That's going to increase your heart rate. Not going to do any of these cardiac centers. Make sure you know everything with a box, and then this has a box somewhere else. Brachiocephalic trunk, that's an artery. Left common carotid, left subclavian. There's my arch. There's my descending aorta. Pulmonary trunk, pulmonary arteries. Superior vena cava, can't see the inferior vena cava. Right auricle of the right atrium. There's my ventricle is under here, but this shiny layer, that's my epicardium. There's my apex. There's a vessel running here that's kind of important. A lot of people call it the left anterior descending. I call it the anterior interventricular artery because it just names where it's at. It's on the anterior side. It's in between the ventricles, right? We'll talk about that a little more later. This on the back side of the heart, you know, you're on the back side because the fat makes a T, right? And this expanded blue vein, the heart has its own little, you know, arteries and veins. And so as this drains back into here, it's expanded. That has to empty into the right atrium. So the right, you know, this coronary sinus empties into that right atrium. So if you're in the right atrium and you could look around, you go, ooh, there's an opening there. That's my superior vena cava. There's an opening below me. That's the inferior vena cava. And behind you would be the opening of the coronary sinus. It's pretty tiny. This they drew kind of in the wrong spot because really it's over here. But that's what used to be the foramen ovale. But now it's just a scar because this is an adult, so they call it the fossa ovalis. But it used to be the foramen ovale. That's just your normal blood flow through your heart. Just follow with me. Superior and inferior vena cava empty into the right atrium. You go through the right AV, and now you're in the right ventricle. Now, when the ventricles contract, the blood on this side the blood on this side goes to the lungs through the pulmonary valve. Okay. Then after it gets oxygen, then the pulmonary arteries, pulmonary trunk, pulmonary arteries. Then when you come back, it comes back through pulmonary veins from both sides into the left atrium, left AV, left ventricle. Now you got to get out, so you go through the aortic valve and into the aorta. Got it? I think you do. This we already did. There's your neutrophil. There's your monocyte. There's your lymphocyte. Don't forget your platelets come from megakaryocytes. There's your intercalated disc in between some cardiac cells. And there's your vessels. I don't like this too much, but that's tunica interna, tunica media, tunica externa. You know that's an artery because it's ruffled. A vein's going to be smooth inside, not going to have as much muscle. These are just really bad examples. Just look in your book. They have better examples. And then we're done. Okay, so stop sharing. And then we're going to go end meeting. And we're going to go end meeting for all.